Good evening. Welcome to another edition of Public Access, Public Affairs, the show that is an award-winning demonstration of what the use of media source offers to our general community. I'm your host, Robert McKinley Gilmore Sr. I'm certainly happy to be here again to talk about mental health. The idea that we need to find support, resources, services, professionals, and ideas that might give us some help in the community. Tonight we have a phenomenal panel that's going to share with you. I want you to call your friends, your neighbors, your family members, let them know right now you might be able to find some help or find an idea how you might be able to get help for your church, your organization, your business, your loved one. Right now, I'm going to start the introduction, let them introduce themselves. Start with my left, my very good co-host friend.
Hello, my name is Reverend Dr. Carl Matthews, and I am the Executive Director for Christian Life Ministries, and I work with helping and working with the faith-based community in implementing faith-based health ministry and recovery. In addition to that, I was commissioned, I found this not long ago, in 2012, commissioned by the General Board of Church and Society to work with the faith community in dealing with health and addictions, drug addictions. So I'm glad to be on the show today. Thank you.
I'm Dr. Matthew Stanford. I'm the CEO of the Hope and Healing Center and Institute, and we offer training, educational and awareness seminars, and resources, services for people with serious mental illness for here in the community.
I'm Dr. Zina Bell. I'm a psychologist in private practice. The name of my clinic is Bell Psychology Clinic. I do a lot of individual, family, and work with children and adolescents. I also enjoy community outreach work. Given that there's a stigma associated with mental health, I try very hard to penetrate the African American market to provide services that are culturally competent. I'm so glad to be here today.
Hi, I'm Dr. Laura Marsh. I am the chief of the mental health care line at the Michael E. DeBakey VA Medical Center here in Houston, Texas. I'm a geriatric psychiatrist, a neuropsychiatrist by training, and I'm delighted to be here to take part in your program.
Well, let me say thank you again to all of you, and certainly I want to start off by asking a very simple question, one or two questions. But first, I always try to give some definition of meanings. This was a definition given to us, really, because I was a part of that same commissioning with the General Board of Church and Society with the United Methodist Church. But they gave us a definition from the World Health Organization, and it defines mental health as a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. That's the World Health Organization definition, as part of the plan that they have initiated from 2013, I think, to 2020 for any number of nations. But how would you, any one of you can, after listening to that definition and knowing the population, how do you see that definition? Any one of you?
It was kind of broad. And when you were talking about it, it made me think about everybody works, everybody plays. It's how we go about that. And oftentimes, mental health or mental wellness can affect how we work and how we play. So it was a long definition, but I think it got to the point that what is interfering with the ability to function in our communities, in our families, in our relationships. So I like part of it, but it left out a part.
Okay.
Yeah, my thoughts are, I think it's interesting in that definition it talks about coping with stressors and ongoing things. It talks about functioning and connecting to the community. And I think one of the things that people don't understand when someone is struggling with a mental health problem, when they have, say, a mental illness or mental disorder, is that it's not that they just have some very simple illness that if you just take a pill, it goes away and it focuses on one little problem. Like, for instance, their mood is low because they're depressed. It causes them not to be able to cope with ongoing stressors. It causes them not to have functioning relationships. It causes them not to be connected to the community. And so in a sense, they're torn away from all of that. And it's a much broader effect than I think most people understand. And so a lot of times I see families and individuals kind of looking or saying to people with mental illness, you just need to kind of just stop it, and get up. And I think that's a nice definition of mental health because it's so broad. I think, unfortunately, when we think about mental illness, we tend to kind of narrow it down.
Well, so as a psychiatrist, we focus on and we learn to treat mental illnesses, but even someone with a mental illness can have mental health. And you can be quite severely ill with a condition, say schizophrenia, and yet you can still have mental health. And so one of the definitions that we use as we have evolved in overall mental health practices is what we call a recovery-oriented approach to mental health care. And that promotes wellness, but also the ability to engage in a meaningful life, and whatever that means. But it includes having a sense of hope, having interactions with your community, but most of all, having a meaningful life. And that would be defined by that person, not by you, but by right. That individual. So that's really important, I think, and it's been a big change in our approach to psychiatric care overall.
I would like to chime in on that because I think that's very interesting. As I listen to you speak about that, a person, I think you alluded to the fact, a person recognizing their behavior or when things is kind of disruptive. Mm-hmm. I find in many situations that some people find abnormal conditions to be normal conditions when it should be abnormal. Mm-hmm. So if you're functioning in that mode, how do you recognize that you're dysfunctional? That you're dysfunctional.
So you mean they're caught within a abnormal process and they don't recognize that they have that they're functioning abnormal.
Exactly.
And a lot of times, and I'm sure Dr. Marsh can speak to this too, a lot of times individuals that are struggling with these problems don't have a lot of insight into what's going on. And in fact, many instances, they'll tell you flat out, there's nothing wrong with me.
Yeah.
There's something wrong with you.
Right.
You don't understand what's going on. And you still are able to work with that individual. I think what what I'll tend to do is I'll tend to draw back and not focus so much on the illness or the diagnosis, but focus on the kind of circumstances around it and maybe ask questions like, well, are you where you'd like to be? And how are your relationships going? And, if they're to say, well, you're not really getting along with my wife very well or my mother or whatever, well, then we can easily focus on that. And then that begins to allow us to kind of draw in. And like what Dr. Marsh said, a recovery kind of oriented process where you're saying you can be better than you are today, kind of regardless of what you're dealing with, is very different than what we kind of used to think of. But I think that's a very good point. A lot of individuals really lack insight, and they honestly don't, because their perceptions are so off.
Sure.
They honestly don't appreciate how abnormal or odd their behavior is in many instances.
Yeah.
And it can be very frustrating for families.
Absolutely.
I guess that's one of the dynamics of the DSM-5. It seems like there was a significant change in elements in the DSM-5. For those of you who might not know in the audience, the DSM-5 is the latest edition of the manual used for the assessment and the diagnosing of people when they have a mental illness, similar to what you were saying, Dr. Bell, about the schizophrenia or some other illness. But a lot has changed from, I guess, DSM-1 to DSM-5.
Well, I think that's interesting because then you have to bring into the sociocultural piece. What was abnormal in DSM? Well, people kind of don't like DSM-2, but what was abnormal in DSM-1 may not be abnormal in DSM-5 because as a society, we've changed, and I think that's interesting.
Now, the DSM process started how many years ago?
I don't know. I'm not a
I'm not
historian.
trying to date anybody,
No,
but Dr. Marsh,
I can talk a little bit
Okay.
about it.
do that.
So the Diagnostic and Statistical Manual of Mental Disorders,
Right.
and I can't remember exactly when it started, but I
Right.
know it's been around since the 70s and possibly before that. But it started off as sort of a way of just describing different psychiatric conditions and what the phenomena were. And in part, what it did was it helped the psychiatric community have a conversation with one another. So what I was calling bipolar disorder or major depression in Houston was going to be the same as what they were calling bipolar disorder or depression in London, England.
Right.
So we all had a common language that way, and we could begin then to use these diagnostic categories to conduct research. And then it took on a life of its own. It began to be used for, insurance purposes, and so that if you needed to get coverage for a condition, you needed to have 5 of the 9 symptoms for depression. But if you only had 4, you might not meet that criteria. So it has a life of its own. Some people have gone so far as to call it the Bible of psychiatry. I would say it is absolutely not the Bible of psychiatry. It's just a current catalog of really a phenomena, and they've evolved it over years to. In the most recent iteration to involve more assessment tools as well as looking at function. But still in psychiatry and psychiatric practice, we don't have things like a blood glucose level that we can use to say, oh, well, now you have diabetes or now you have major depression. We have to still look at the phenomena, the features that the person experiences, and also we observe as clinicians to make those diagnoses.
Well, do you see the evolution, I guess, between different definitions? Certain behaviors are no longer in the latest edition that were in 4 or 3. They're no longer there because of, is it society now accepts the behavior, or the behavior has been changed, or,
I would say that like for instance, I'll give an example of one that was in and wasn't. So and maybe it's a little bit of a nuance, but Asperger's syndrome was in, and now it no longer is in. And then Rett syndrome was in there, and that same little autism, kind of trying to figure out autism. Well, now we just have a spectrum, and so you fall on the spectrum based on kind of the severity of your autism, and so you can be more or less autistic.
Right.
And so people that had Asperger's syndrome would have been on the very high functioning, very, very high functioning end, but they decided that it was more clinically relevant and meaningful to just have a spectrum. And that's what they, I certainly don't want to ever be looked at as the defender of the DSM because so many people have attacked it, but I mean, I use it myself, but the thing is that they try to make it clinically meaningful and kind of more in a sense that if I say someone is on the spectrum here versus calling someone Asperger's, does that help me in dealing with their distress, in dealing with their family, and those types? So is it clinically meaningful from a treatment perspective, and also from a categorization way, like Dr. Marsh said? And I think they've done a good job of kind of taking some out and putting some in. There's always going to be arguments. Unfortunately, the manual is, it tends to be a little bit more based on kind of committee meetings than on actual empirical research, depending on the diagnosis. Some are really very empirically oriented. But overall, I think they've done a very good job in the most recent one. In fact, it's of the ones that I've had to deal with since I started, which was the 3, then the 3R, and the 4 and the TR. I think there really is the best they've had.
Latest one.
And I think it's the one that we can understand the most. And I think I've also seen some of the most consistency in diagnosis. If I were to diagnose somebody with something and then Dr. Marsh diagnosed the same person and we didn't have a common reference, that's really going to impair their ability to get treatment. Now, it's not to say that I might not look at someone and say they have X. I might say they have schizoaffective disorder, and she might say they have bipolar with psychotic features, you know, and so, but the reality is that those would be relatively close together.
Right.
And, but I think overall they've done a good job. I do think people get too caught up in diagnosis, though.
Right.
I think the reality is we need to be more worried about, we're looking at a person that's distressed, and how can we help them with their distress, how we can help their family with that distress, and how can we help them move forward and live a quality life regardless of what issues they're dealing with.
I have a great appreciation for what you just said. You know, in the African American community, I really did not get introduced to diagnosis or DSM-4 until 2010. And just reading that and just seeing those different diagnoses and how that define personalities was overwhelming to me. And you know, and I think that it does have some validity in the sense that it makes a person try to understand what their loved one may be going through and how to support them. But then, you know, for the African American community, for years, when you start talking about disruptiveness in our life, you know, which that could be a lights being turned off, no food in the house, terminated from the job with a diagnosis. And what has been the therapeutic process for us has been the church. And that's why I work so diligently in working with the faith community to not categorize everything as demonic or evil, but then also have some practical approach to either navigate a person that's beyond your scope of ability to counsel to professionals like yourself, to get them some support and help that family to deal with their loved one who have this strange behavior that they don't know what to call it. They just know it's strange, they don't know why, you know, and they don't know how to support it. And many times, because of that dysfunctional abnormality, they are discriminated against, or they're disassociated from, and they're isolated, which can attribute to a lot of exacerbated behavior to criminal acts or any other, you know, other things to get attention. Say, hey, I need help, you know, but they don't know how to ask for help.
Dr. Bill, how do you see that?
Well, no, you know, I think one of the things that's been helpful with the DSM is that a person can say, look, I'm in a book. I do have an idea of what's going on with me. I'm not the only one. And you can sit down with a family and you can say, oh, here's generalized anxiety disorder. And one of the core features is that you worry. Oh, okay, so I have a name for this. And let's go through and use it as an educational tool.
Absolutely.
And I think having a framework to say, excuse me for using this word, I'm not crazy. No, there are problems with thinking, problems with feeling, problems with living. It doesn't necessarily mean that the C word. So I think it's helpful from an educational standpoint. One of my concerns is that it doesn't necessarily help me with treatment. That, you know, I have to know how, what my strengths and weaknesses are in terms of treatment, or what would be the most effective treatment that would be useful. And does the DSM help you out with that in terms of treatment?
I think it helps us out in combination with the research literature, because we're able to say generalized anxiety disorder, for instance, here's a group of people with generalized anxiety disorder, and we've done this therapeutic approach on them, and this therapeutic approach, and this one doesn't work.
Okay,
so don't do that anymore.
One, don't do that,
and so, but I would say that we're only in our infancy of really being able to do that effectively in psychology. You know, so you and I being in psychology and you in psychiatry, I think we're much further down the road, obviously, with medication. But psychotherapeutically, there's a huge argument right now about, should you just do individualized care where, just because you found that a group doesn't work for this group, I think it works for this patient, maybe I should go ahead and do that. I mean, there's a lot of argument with that. I mean, I don't necessarily agree with that, but I think that it does help in that context. You're right, the actual, what's written in the DSM itself does not give you any particular guide on exactly what to do.
So it's good for populations in a sense, but then when you have a family that's struggling and they don't know what's wrong, and you pull out the book, it's a fantastic tool, as you said, to say, right, this is, this isn't just your brother being difficult. Your brother is depressed. He has a mood disorder, and this mood disorder, as you can see in this book, people they don't have any energy, and they feel low, and they feel hopeless, and they can't concentrate. There's a reason why he's not going to work. It's because it would be like walking through, quicksand every day to try to make it through your day. And so that's the condition he has. And just as if he had, a pneumonia, you wouldn't expect him to be getting up and being bright and chipper if he had a pneumonia. He's got a major depression, a mood disorder that we really need to be compassionate about and understand and help him move forward. And that's really where I think when you're working with families, as you said, you get to the point where you can provide all the support and faith and love, but sometimes a person needs additional professional help from a mood disorder expert or a psychologist. But I do want to say with the psychotherapy, what becomes really important with the diagnoses, and I'm thinking about PTSD and veterans, and we use a number of evidence-based psychotherapies that have been shown to be extremely helpful for individuals with PTSD. One of them is called cognitive processing therapy. Another one is called prolonged exposure therapy. And we have patients at the VA, when we look at our group of individuals, they start off with, say, for example, a high blood pressure in the abnormal range. Their PTSD scores are, say, at 85%. And after treatment, they go back into being 60% of them will be in the normal range. They no longer have high blood pressure or high PTSD. They still have the condition, but it's treated by psychotherapy. But not everyone. Some people need something else. So 60% might get better with that psychotherapy. 40% need the psychotherapy. Maybe they need another psychotherapy. Maybe they need medicine. Maybe they need to work on their relationship with their spouse. Yeah, so we really can use the diagnoses help us identify a treatment, but it's never just one thing. We all live in a community. We need to work with each other, understand each other, care for each other.
I guess that's the strength to me of this definition, because you are trying to educate the public. Seems like the person that's been being affected is affected.
Right.
AFF. But the public becomes affected. The family, and they don't know what to do. We were talking about a couple of situations, and I think to me it's like all of a sudden this illness has affected their loved one, whether they came from the military or were at home one day or whatever, went to college and just bombed out and came back and was a changed person. Now it affects everybody around them, because what's the number? I think every person's impacted with a mental illness affects 7 to 10 people. You start adding that, Dr. Stafford, your research now. You have to tell us. I was impacted when I heard your research 4 or 5 years ago. Share that research with us, because it was just so impactful.
Well, yeah, I mean, first I'll make a comment in the context of what you just said.
Yes.
I think you're absolutely right. When there's a stigma and a shame associated with mental illness, mental health diagnoses that you do not see with other diagnoses. If somebody is told they have cancer, people rally around them to support them and serve them and care for them. Somebody is told they have schizophrenia, everybody runs for the hills. And they don't want to have anything to do with the family, and they don't, and a lot of times they'll say stuff like, well, I don't know what to say. Well, say something, I mean, so it's just a different, so there, in the context of what we're talking about, but giving someone a mental health or mental illness, mental disorder diagnosis, there is a shame and a stigma associated with that other professionals in the medical field don't really have that. Now, as far as the research that you're talking about, I've done a lot of research in the context of access, particularly how people with mental health problems access care through faith communities. What the research shows is that, and the National Institutes of Health have found this, that individuals in psychological distress are more likely to first go to a clergy or a ministry staff person before they go to a physician or a mental health care provider. And it's an access issue. A lot of times they don't understand what they're struggling with, And it's very easy to just walk into a church. There's no shame. There's somebody there that would care for you. And so they're more likely to do that. And what's really interesting about that statistic is in that one of those original studies, it didn't matter whether you were associated with the faith community or even believed in God. It was just you were more likely to access it. Now, what happens, unfortunately, is the majority of faith communities, they don't recognize that there's a mental health problem sitting in front of them or how to handle that. And so that's one of the things we do through the Hope and Healing Center is we have a program called Mental Health 101. We go into faith communities, train the clergy, train the leadership, help set up support groups, set up a healing community there so a person can begin to act some level of support and care there, but also teach those clergy and individuals that are working on that staff how to make a referral into a professional network so that to the right kind of provider, because a lot of times, and I'm sure Dr. Marsh can speak to this, so can Dr. Bell, a lot of times you get one chance. If they'll seek out help, and if they don't get assistance,
Then
that's it.
What do you mean? Clarify.
I mean, if they go into a faith community and they say, I'm in distress, and let's say that pastor over spiritualizes it, say, I'm just going to pray for you, brother, and everything's going to be good.
We've heard that before.
And they do that, and everything isn't good after that. They may very well, what our research shows is they very often say, okay, well, I tried. I tried to get help, and it didn't work, and so this is just how I am, and I'm just going to be like this. And they don't go to professionals. They don't go. And our research in Waco, actually, when I was at Baylor, actually showed that a very large number of those people then actually pull away from that faith community.
Really?
And so, they're seeking assistance, and then they're made to feel as if now they're just a bad believer. And I think one of the statistics that really, really touched you was that a lot of pastors have, I interview a lot of pastors from my writings. A lot of pastors have said, well, those things don't happen in the church like they happen out in the real world. So we did a study where we actually used over 6,000 congregants from 7 different states, 4 different denominations, looking at the prevalence of mental health problems in them, exactly the same as the general population, right around the 25%, no difference. And then, unfortunately, what we found is that when you ask when you ask them what they wanted the church to be helping them with, they, named off mental health problems and that. When you ask people that didn't have mental health problems in their family, they said stuff like retirement and stuff like that. They didn't even recognize that mental health would even be an issue. And so most of those people are invisible in those faith communities. And, we're desperately trying to kind of help those faith communities recognize that they have a great opportunity to be a front door. And what I also say is they're a front door, but they're also a long-term healing community. Because if you help someone get to care and get better, they're going to come back, and now you have an opportunity to walk along with them for the rest of their life.
And Dr. Stanford, that's why it's so paramount that there be a strong power of advocacy from the church perspective to create a safe place for when people have problems and these type of challenges, that parishioners or pastors or members will know what to do, practical approaches to what to do to assess that situation and really have some way to case manage it with the referral source so that you can get a person real help. Because, I'm not taking anything away from prayer. Prayer works, prayer is powerful. But a person needs something more to go along with that. Because you pray that 15 minutes, if that's the case. You send them back to that same environment with the same problem, and we don't know what that environment is, right? Even if they're going to even make it through the next day, right? And you never see them again. Like you said, we have that one opportunity. I've had over and over again parishioners to say to me that she was embarrassed to go to the church because, again, it may demonstrate or imply that they have no faith. That's embarrassment. And they're dealing with a person, a husband who is aggressive with this disorder, physical, abusive. They don't want to put him in jail. She knows he's sick. Only a few members you can talk to. And another thing that our faith community must learn to have is confidentiality. Protecting a person who come to you who's in distress mode that way, in a desperate situation, that they can feel comfortable that their information is not going to be shared throughout the church to where they never return. That's just not what Christ intended for the church to be. We should provide a safe place.
But Dr. Bell, how do you distinguish between the two? I mean, obviously, when you start saying diagnosis, that's another level. But then, like what Matthews is saying, then a person comes in, possibly has no diagnosis, or nobody knows of what it is in the church. Now you have a dilemma, in a sense, between the belief, as Dr. Sanford was saying, with the church, spiritual side,
Right, yeah,
and the reality of whatever the stresses are that has caused or exacerbates the illness.
Okay, so it seems like there's three parts to your question, but the part that jumped out at me is that there's this either or. Either it has to be a diagnosis or it has to be a lack of faith. And what I found that really helps is if you honor the person's faith and their spiritual strength. So it's a question of, have you prayed about this? Who have you prayed about this with? Can you pray about this with me? So you still include the spiritual strength, and then you shift the focus a little bit. Now that I've established that your spirituality is a strength, in what other ways can we use your spiritual strength? How can I pair this so that we can talk about your depression or we can talk about your anxiety? Now, one of the things that I've been concerned about is that someone may say, because I'm anxious, that means I don't have enough faith. And what we'll talk about doing is, let's come up with a relaxation strategy that incorporates prayer. And the classic one is, yea, though I walk through the shadow of the valley of death. But you start incorporating the spiritual beliefs into techniques that I would use in my office. So I can say that with anxiety disorders, I've been very successful at incorporating prayer as a form of relaxation and meditation. Did I answer part of your question?
Yeah, it does. Dr.
I'm gonna build on that. I think that part of a recovery-based approach is definitely using people's strengths. It's a strengths-based approach, and if one of your strengths is that you have a lot of faith, you want to incorporate that into your treatment. There may be other strengths, maybe that that you have a good relationship with your children, and they can be a part of that. But in particular with the faith, sometimes I've had individuals who, again, the idea of being treated for a mental illness is something so horrific to them that they think, again, I must not be good enough in the eyes of God if I have this. And I've had to say to patients, God wants you to take an antidepressant, and, because that's what's really going to help you at this. This is wherever that's coming from. And we have to help people understand that treatment works, and that treatment, people get better, treatment works, and that the biggest deterrent so often to treating a mental illness is all of these beliefs about treatment, the belief of non-response, the myth of non-response, as it's called. And so to help people understand that, this idea of stigma, not only just going to the pastor, but at the VA, we have one chance as someone walks through that front door, through those electric doors, they open up, and if the person is not looking right and they don't feel welcome, it can be very hard to get that person back. They say, I went there and no one helped me. And it's like, we're all there waiting to help. But if they feel that, and so sometimes you have to have a buddy come with someone, and someone who can be their advocate. And so again, that's part of the strengths-based approach. If it's the pastor who needs to come with someone, bring them to their mental health appointment. That can be critical, and to be able to say, okay, your pastor is going to stay with you as you go through this, and we're all going to work together. And I think that can really go a long way.
May I interject? Because I love this stuff because it's so real, and people are really impacted in a real way. And our churches, God bless the church. I love the church. I am the church, but we're so unequipped in handling real life critical issues. Real story. What do you recommend that the church should do when there's a family? Blended families are pretty common these days. And a woman who is with a man, married, and they have children from previous marriages. The older son end up having incest, or should I say sex, with the daughter to the mother. And he's abusing her. He's older, she's younger. And this goes on for years. Finally, she comes out. Now, part of this, which helped me understand how many people suffers silently. And she's dealing with this because she may feel that she's a problem. She's dealing with guilt. She don't want to be the reason for this family to break up, all these things. So they're in church. And obviously the service was moved in a very high-spirited way, and the young lady was very disturbed. And so finally she comes out with it. And she's talking to a counselor at the church, right? And put that out there. Well, churches are unequipped to know how to handle that from a counseling perspective and from a liability perspective. And so I think these are the kind of things that we have to equip our parishioners and pastors about. So when these things happen, that it's more than prevalent. We know exactly what to do to navigate this family and this little girl who's been impacted in a major way to get help. So from professional, I mean, what would you recommend that we do in a situation like that?
Well, I think that, one of the things, and you make a great point. I mean, one of the things is that churches have had a tendency to, and I don't know why we've done this, but we have decided that we only do the spiritual and the world does all that other stuff. And so that, abuse and mental illness and sickness, they do all that and we'll just do the spiritual stuff. And the reality is that we do everything. And so we have to have our fingers in everything. And so I think, if I was a pastor of a church, I would make sure that my staff had had a suicide training. I'd make sure all my staff had a training on child and elder abuse. I mean, there are plenty of nonprofit organizations in the community that would come and do either one of those trainings. I would make sure that I was offering support groups at my faith community. I would make sure that I had a pastoral care team or a set of lay counselors that have been trained that could walk along with people. And I would also make sure that I had relationships with organizations and individuals in the community that could, like Dr. Bell, that can provide services that I've talked to, that I have a relationship with. And as Dr. Marsh mentioned, an absolutely foundational thing, and that is working as a team.
Yeah.
Being able to, say if I'm the pastor, I've referred you to my good friend, Dr. Bell, and we're working together and we have a release of information signed and we can talk to each other and that information is confidential between us, but we're working together and that can be done with all types of things. I mean, churches run health fairs and do diabetes screens, but then we ignore mental illness and trauma, and so,
Absolutely.
I think trauma is one of the biggest issues right now that the church has an opportunity to make an absolute incredible impact in, but I think people, like you said, they suffer in silence,
Yes.
even in churches.
That leads me to think how veterans have to endure it. I know.
Can I say
Of course,
something
okay.
real quick?
Go on.
So another idea would be to have some type of group or a topic discussion that specifically talks about types of trauma. Just not pinpointing anybody, but just a little bit of education. These are the different types of trauma. And you say historical trauma, abuse, domestic violence, but you give people definitions and types of trauma so that they can begin to think about, this has hurt my spirit, this has hurt my family, this has hurt. That's my one.
Sure.
That's a lot of digging too.
Sure.
I'm just saying it's when you start opening the door.
Right.
Right.
Oh,
Right.
that's why people don't, because they're afraid what's going to come out.
Exactly.
And so,
Yeah, but,
Right.
yeah,
Right.
but the VA has annual. This is the annual event, and you give people a chance to understand it from the view of a veteran.
Right.
My first point is are the numbers still 20 a day of committing suicide?
Right. That is still a problem. And what we want to do and what we have with our annual mental health summits, these are actually Congress mandated that every VA facility in the country since 2012 has an annual Veterans Mental Health Summit.
Right.
So, and what we aim for in our Southeast Gulf Coast area is to work together from the VA and all of our community partners, which are many, faith-based communities, government agencies, practitioners, social service organizations, schools, employment groups. We get together for a day of learning with the idea being that we can, by knowing what one another is doing and by learning about veterans and veterans' mental health issues, we can refine and further develop a system that can respond to veterans and their families wherever they are, and that we will know what I do, but I also know what you do and what you do and what you do, so that we can all work together and collaborate, so that we have more of a network, a collaborative network, that we can work together as a team to get that veteran and their family what they need to improve their well-being, to address their mental health needs in particular. So I can tell you more. I can
No,
go
it's
on.
very diversified. I guess I was looking at the sessions. The upcoming training is going to be on the 17th. Is it
18th.
18th, but the sessions are from one extreme group to another. Could you give me a range, a couple of
Right. Well,
sessions?
we wanted to cover different populations, and so we have one is called When Violence Hits Home. It's on domestic violence, and so we have a representative from Houston Area Women's Center, as well as someone who works with our Veterans Justice Outreach Program, where they provide treatment for veterans who actually commit the domestic violence and help them get into treatment. We have programs for women's, for elderly veterans, homeless. A big emphasis, since our program this year is at Houston Community College, is on bringing in schools, all the various higher education, but also high schools, et cetera, wherever you have, again, someone who touches veterans in some way. And so in a school situation, you have veterans who are going back to school, and there are counselors and teachers who are just thinking, it's a veteran, I'm not sure what to do with this person. But if they can come, those individuals come to our program, they can learn about what are some of the issues that might affect a veteran in terms of their military culture, what are the specific issues that a veteran returning to school might have, and then what are the resources that are available in the community, both at the VA and across the community, that can be helpful.
Now, this might shock the listening audience. I want to ask you this. When you talked about when violence hit home and domestic violence, most people mindset goes to the fact that it's always a male committing violence on a woman.
Right.
But I saw a man 6'5", as tall as Dr. Gilmore, run from a woman who was probably your height, Dr. Bell, as a result of being domestic violence, you know, against. So, I mean, what's been your findings in that view?
Well, certainly there's probably higher rates of male on female violence, but there's also male on male violence and female on female violence. As far as the veterans are concerned, you know, and if anyone is concerned, what we want to do is, in particular as mental health practitioners, identify when there's a mental health condition that may be inciting that violent behavior, whether that's a substance use problem or a mood disorder, because those certainly can, PTSD, those can really contribute to domestic violence. And when someone gets arrested for that, we hope that not only there may be some consequence to their criminal actions, but also that they can get into some rehabilitation, some treatment, because treatment works, people get better, they can get their families back together. And we have a very well-developed mental health court where people who have committed a crime in the context of their mental illness can be more or less sentenced to treatment. And we see families get back together, people get their jobs, you know, they go with the support of our community, they can get back to the life that they really intended to live.
I guess what I'm beginning to clearly understand after all these years is that if there's not a support system, in place, whether it's, you know, on the job or church or family, then people do fall through the cracks. Like Stephanie, they might be in church but still have the problem, you know, and you know, they fall. How can we stop that? Because to me, the more people fall through cracks, the more we as a society overall suffer.
Right. The support is tremendously important, and mental health problems. You know, one of the problems with mental health problems is they cause isolation. people isolate for any number of reasons, stigma, misperception of things, but they isolate. And when they isolate, they don't get better. And so, support groups are important. Supportive communities like faith communities that are healing communities are important. Supportive families are very important. Supportive, city and county structures where individuals with mental health are not looked at as criminals or bad in some way, and they're not shunted into jails and things like that, but they're recognized as ill.
Right.
And so, no, you're absolutely right. I oftentimes think, I deal mostly with people that have very serious mental illness, and so, I kind of think of treatment as kind of a three-leg stool. You talk about medication, talk about psychotherapy, talk about support.
Right.
And, that stool does not stand up if you don't have all three legs. And in my training, I'm very biologically driven.
Right.
I tended to always think about medication first, but in my experience and practice, I tend to find that support is so important.
Really?
And that if you can almost always get the support around someone to be better, even if they don't want treatment, or they don't recognize
support.
Right. They don't recognize that they even have a problem. They may not take medication, they may not go to a therapist, but I can definitely work with the family. I can fix the structure around them. I can set up structures and plans. I can make their environment more healing and therapeutic, and they will start to show progress.
Well, last observation on my part is, as you know, the president's new commission has recommended that we have the president declare a national epidemic because of the
opioids.
600% increase of overdoses. I mean, we never would have thought we saw this 4 or 5 years later, but it's worse, I mean, how should America respond? How should we respond? I mean, we're past the time when we thought we dealt with it. All of a sudden, it's 600%. How should we respond? Last thoughts. How should we respond? And the last element of what you bring to the table for mental health.
Oh, well, I'm still stuck with talking about relationships and how our communities have broken down and how difficult it is for us to communicate. Right. And as you were saying, that you can get people to support each other, to support the ill person or the person that has an addiction, if we're talking about that there's an addiction and we need to do something about it. Right. So your statement was 600% increase. Right. We act as if this is a surprise, and we knew that this was happening. It was tracking. We were seeing it in the news.
That's right.
We were not talking about that this is something bad that's going to happen. It's like we put our head in the sand. Right. And excuse me, I'm going off on a tangent. So now we're going to legalize marijuana, and we don't have the treatment that we need for alcohol abuse or heroin. I mean, so I think that there's something else going on in our culture. I'm sorry.
Well, these are hard topics for people to talk about or admit, and I think addictions affect all social classes. It's not, and when as I say, when violence hits home, when addiction hits home, and then how often does that person actually acknowledge that, oh, it's hitting my home too? And we need people in our community who will advocate for wellness and treating all these psychiatric conditions in the same way that we treat all the other conditions. When you said, if there's cancer, everyone rallies around. The National Alliance for the Mentally Ill has often referred to our psychiatric illnesses as the no casserole illnesses. So
nobody brings anything.
People won't bring you a casserole,
right.
And so when we say that, and then we start saying, you know what? Why don't we just start bringing casseroles to people in your church? Right. And it may not be even just someone with depression. Maybe it's someone who is at home with their family member with a dementia. And that person with dementia is violent. Maybe that person needs a break and some help and some support. And when churches and others start talking about that and saying, you know what, and then they say, oh, well, so-and-so has this problem too, and then say, that my brother had that, and my sister committed suicide, and you find out that, well, what the data show, or that if you look at the lifetime prevalence of any one psychiatric disorder from ages 0 to 85, the lifetime prevalence is 80%. That means 80% of people have at least one psychiatric diagnosis during their lifetime. So there's 20% of the population that's unscathed, and we expect a lot out of them. So really, these are so common, and majority of mental illnesses, they begin in adolescence. These are chronic conditions. Now, many other chronic medical conditions, heart disease, et cetera, they're beginning 40s, 50s, et cetera. Substance disorders, mood disorders, they're beginning in adolescence. And so we have a whole population that's affected greatly by these, but no one talks about it. And it's no different whether it's looking at, marijuana use or alcohol use. And we can do a lot just by talking about, your program is fantastic to talk about mental health, because it gets people talking about these conditions and saying, if they talk about what else is happening and being honest about how common these conditions are, people begin to start looking for help, and they just need to know where to go for help and where they're going to be accepted if they go get help.
Like Stanford, closing thought?
Yeah, I mean, I think, when it's all said and done, I think it comes, when we're dealing with all these mental health issues, I think it comes down to resiliency and coping, and I think, and the support. And I think that, if you want to make an impact in your family, teach your children how to talk about when they have problems, and teach them how to cope with stress. When they're having stressful situations, teach them how to talk, support them, show them how they can be resilient in those situations, give them skills and tools for them to do that, and then support one another, talk to one another. I mean, Dr. Marsh makes a great point about we simply don't speak to one another about our problems, particularly mental health problems. Talk to one another, and that will go a long, long way. And so I really think, for us to make a systemic impact, I really think we're going to have to start with the young, training them that these are illnesses that can be treated, teaching them how to adopt appropriate coping strategies, and helping them understand that it's perfectly okay for them to go get help when they begin to have struggles in these areas.
Wow. Closing thought, Matthew?
Well, yes. I think that, to thy own self be true, that we have to come out of denial and acceptance that we have a problem ourselves, and recognize these problems in our families, and overcome the stigma and the barriers that we face. I believe very adamantly there's a need, a dying need for education and training in our faith community. Pastors, I challenge you, because you need to know those who are on your usher board, your deacon board, in your choir, in your pulpit, and sometimes you who bring the word have stressors that you deal with and anxieties, and we need to have trained people so that people can feel accepted when they come into the household of faith and not rejected. Christ came to seek and save those which are lost. And so we all have been affected and impacted by that. And I just want to say that I look forward to working with every one of you in a collaborative effort. I heard a lot about that. I'm glad to know that our President Trump has made this national call, a commission to deal with this addiction. I'm glad that the Social Church of the United Methodists commissioned us in 2012 to do that, and we've never negated that responsibility.
Right.
But I guess now it's time for us to become more vigorous about it. Yeah. And then, of course, not last but not least, to understand that God has commissioned us to be about saving the lost and loving those who have been ostracized due to unfavorable circumstances.
Well, I want to say thank you once again. We've had a dynamic roundtable discussion about mental health. I want you to know that there are resources and opportunities for you to link in to make sure you can get some training, some education. I think that the Hope and Healing Center is available. You can go online. I think that you need to be able to access the training that's required and make sure you have a creditable link to those types of services. And Dr. Stanford certainly offers that around, not only in Houston, Harris County, but around the country where needed. And also I want to say thank you to the VA the leadership of the VA. I, as a veteran myself, have benefited tremendously. Dr. Marsh and her team have done a tremendous job. The training that's going on, go online. The VA, it might still have some slots. It's usually packed. I can tell you that. I know it's going to be at the Houston Community College facility this year. Looking forward to that in a couple of weeks, a few days down the road. And I'm already registered. You got to register online too, by the way. So, but make sure you are there. You get your resources available, because there's going to be a lot of vendors. And of course, Dr. Bell. Thank Dr. Bell for her long time efforts dealing with this cultural dynamic that's involved in dealing with mental illness. I can honestly say that you've got to get help when you realize a person needs help. And I think for many of us in the community, we see the results of abnormal behavior without a diagnosis. And I think what we've got to do is recognize that it does take a community, and we are the community. And because of entities just like the Houston Media Source, which is celebrating 30 years. And I want you to know that that 30 years has been based upon providing information, education for individuals in the community. You can also look forward to seeing some of these clips online, the YouTube, and sharing them with other individuals who need that kind of information. And they've been here for 30 years. They're going to have a tremendous program this weekend. I'm going to be there. I've already signed up. Hope you do too. I want to say congratulations to them. And we look forward to being here again to help you get some mental help. This has been Public Affairs, Public Access. Until we meet again, I hope you know you can get some help. It's a blessing.